Bonjour et bienvenue à Québec. Welcome to Quebec City. Have a good morning. I'm Gilbert Aymon, Social Science Track Chair for this conference, and I would like to welcome you to the keynote speaker for social sciences this morning. I'm speaking of Adam Bourne, who is professor at the Public Health and acting director of the Australian Research Centre in Sex, Health and Society at La Trobe University in Australia, at Melbourne. A health psychologist by training, Professor Bourne leads a large program of LGBTIQ health and well-being research, including HIV social research, mental health and alcohol, and other drugs use. And he has published numerous papers examining the topic of sexualized drug use that we also call chemsex. Highly engaged in policy and programming, Professor Bourne is member of the Victorian Hall of Government LGBTIQ Task Force and co-chair of its Health and Human Services Working Group. Let me add that to this official bio that he is a professor at La Trobe University, which is a university that influenced a lot of our understanding when we created the Omega cohort more than 26 years ago. So the influence of La Trobe University in our world is close and very interesting for understanding the culture of gay men, MSM, and what are over the practice, what are the meaning of having some relations and some practices that are supposed to be at risk for HIV. Also, through the first exchange that we had with Dr. Bourne this week, we found very interesting to have a close contact with him, but that was not only with him, which is a charming man, but also to have a network that is overlapping together. So his colleagues are part of our networks. Even being from Australia, he is from home, he is from here, and I would like you to welcome this man that is only 2 degrees apart, or maybe 1 degree apart of separation from us. The world is small, but it's very warm. So please welcome Dr. Adam Bourne, who share a lot of things with us.
Merci Gilbert. Bonjour tout le monde. C'est un honneur d'être ici pour parler à la conférence. Maintenant, je vis à Melbourne en Australie, mais je viens de Pays de Galles. Comme la plupart des Britanniques, mon français est terrible. Donc, j'espère que vous comprendrez. Je continue en anglais. Je suis désolé. It is a real honor to be invited as the keynote speaker for social science at the CAHR conference, and I offer my sincere thanks to the conference organizers and to all of you for attending this morning. I also want to acknowledge the traditional indigenous custodians of the land on which we meet. And as is customary in Australia, I acknowledge that I work and live on the unceded lands of the Wurundjeri people, and I pay my respects to their elders past, present, and emerging. 2023 marks 10 years since the first academic article emerged that utilized the term chemsex, often referred to here as party and play. You can use those 2 terms interchangeably. It's a term that originated in community and has evolved over time and can vary across countries and contexts. But no matter the term used to describe the phenomenon, it has evoked considerable attention from community, researchers, public health officials, the media, and even politicians. The 10 years have witnessed hundreds of research papers and reports relating to chemsex. There's been papers that identify the practice, ones that describe the social and cultural context of engagement, papers that sought to better define what chemsex is and what chemsex isn't. And we've critiqued chemsex as a social and cultural practice, and we've theorized the forces that shape engagement. We've measured it in a myriad of ways, and we've sought to understand patterns in use and patterns in consequence. And we've responded to it in clinical practice, in psychological practice, and in community-based organizations. I'm going to touch on each of these elements during my talk this morning and try to piece together the things we can say with confidence on the basis of this research and the things that are left to be said. Many of you will be familiar with chemsex already, but let's start at the beginning and ensure we're on the same page when it comes to understanding what we're talking about. Using drugs in the context of sex is not a new phenomenon. People from all walks of life have been doing so for decades or even longer in the form of alcohol or other drugs. What's changed over time is the types of drugs that can feature in a sexual encounter and the effects that these can have. While drugs like ecstasy or MDMA might make you feel tactile or euphoric, new stimulant drugs entered drug markets that brought about an intensity in sexual experience that hadn't quite been the case before. They could raise your heart rate and your blood pressure, as other stimulants could do, but they could also trigger quite intense feelings of sexual arousal. They could make you feel horny. And this intense sensation could last for much longer, shaping different kinds of sexual encounters. Anyone could, in theory, go out on a weekend, get drunk, or take some drugs while out socializing, and then have sex with someone. But in this instance, that sex would be largely coincidental in nature. It wasn't the reason you took drugs in the first place. It's a kind of sexualized drug use. One key way of distinguishing chemsex is the intentionality of use. It's using specific drugs that have a specific effect for a specific purpose, such as making sex more intense, more arousing, or making it last longer. This table is drawn from a paper I recently wrote with colleagues from Taiwan, and it seeks to break apart the drugs that are most commonly associated with chemsex due to the effects that they have on the sexual experience, and distinguishes them from drugs that can form part of a more general sexual scene. The chemsex drugs we most commonly point to, given the nature of their effects, are methamphetamine, a synthetic cathinone called mephedrone, which is a bit more common in Europe, I think, than perhaps over here in Canada, and then gamma hydroxybutyrate, or GHB. Using poppers, by comparison, is commonplace among gay and bisexual men, but I don't believe it would be appropriate to frame all poppers or amyl use as chemsex. The effect is short-lived, it doesn't trigger the same kind of arousal, and it's rare for users to describe the same kind of intensity of experience. It's a practice that typically occurs in private homes, usually facilitated by gay hookup apps, although it can be commonplace in saunas or bathhouses in many parts of the world as well. While it can occur in the context of romantic relationships between just two individuals, it's common in group sex situations and as part of more casual hookups or with fuck buddies. In the majority of cases, the drugs involved are swallowed, smoked, or inhaled. Injection drug use is less common in the majority of countries, but where it does occur is often highly stigmatized by other gay and bisexual men. It's often referred to as slamming, which is partly a way we think of distinguishing this act of injecting from other contexts of injecting that are perceived as lower status or even more stigmatized. As I alluded to at the start, there's a range of terms that can be employed which have evolved over time. You see party and play used here a lot, and in the Southern Hemisphere and in some parts of Asia. But as I said, you can use party and play and chemsex largely interchangeably. Among gay men themselves, if you look on some of the hookup apps, you'll see all sorts of words that denote chemsex, such as high and horny, M-play, T-play, wired play, or chilling. And interestingly, in Taiwan, you often see men on their profiles include the names of characters from the Disney movie Frozen, La Reine de Neige, and it's because the lead character in Frozen is Elsa. Elsa is an ice queen. Ice is a street name for crystal meth, so pretty creative, I thought. Before moving on to talk about how prevalent it is, I'll preempt a question that I often get asked about chemsex and whether it's unique to gay and bisexual men. The answer, of course, is no. It has been observed among other populations as well, although the research is at a much earlier stage of development. What little work has been done to date suggests that it's not commonplace among heterosexual men and women. 1% or less of those attending sexual health clinics in England, for example, but there are some indications of drugs being used among lesbian, bisexual, and queer-identifying women to facilitate sex, although not always the drugs that they're using are the ones that we most commonly associate with chemsex, which speaks to the issue of definition I'll come to in just a moment. There's been a large amount of community, political, and public health attention on chemsex, prompted by what at times has been some pretty hysterical media reporting. Suggestions of a new epidemic of dark, grainy images depicting debauched sexual activity that is overwhelming the gay community, the kinds of images and rhetoric that I don't want to perpetuate in this talk. Such discussion, however, has prompted considerable efforts to try to understand how commonplace chemsex is and among whom exactly. But the answer, of course, depends very much on how you ask the question. It's been a significant challenge to establish the prevalence of chemsex and to compare from one context to the next, given the wildly different ways in which it's been assessed. As a starting point, are you measuring chemsex specifically or sexualized drug use more broadly? What definition is provided to participants? Are we assessing engagement in the last 3 months, the last 6 months, the last 12 months, or ever? Is it the use of certain drugs in general, or their use only in certain settings? Beyond these pragmatic and conceptual questions, where you ask the question has prompted considerable diversity in findings. I once witnessed a media explosion around chemsex in the UK, which was triggered when a journal article was published stating that 52% of gay, bisexual, and other men who have sex with men engaged in chemsex. Digging into the detail of the study, it quickly became apparent that it was conducted in an inner-city sexual health service that is known to specialize in chemsex issues. Hence, many gay and bisexual men engaging in chemsex went there in preference to other services as they knew they'd probably get a better standard of care. But even when looking only at clinical settings of data collection, variations in how you ask the question have prompted some very different findings. When asked in the past 6 months, how often have you used party drugs for the purpose of sex, 16.9% said that they'd done so at least a few times. A subsequent question in the same survey asked, in the past 6 months, which of the following substances have you used before or during sex with men? This time, 54% ticked one or more of these substances, although not all are ones we would typically think of as chemsex drugs. If we take a very brief tour around the world, we can see indications of chemsex prevalence, although nearly always asked in different ways. An online community survey of MSM in Australia in 2019 found that 14% had used crystal methamphetamine in the last 6 months. And crystal meth is mostly associated with sex among this community. It's less often the case that it's used for other purposes. A survey of Celtic nations, the British Isles, conducted in 2018, asked MSM when they last used crystal methamphetamine, mephedrone, GHB, and also included ketamine within this definition. 18% had done so at some point in their lives, and 8.2% in the last 12 months. So a reasonable proportion, but a long way from being a majority. A survey I ran with colleagues in 2019 of more than 12,000 men across 54 countries of Europe found that 6.8% had used either crystal meth, GHB, or mephedrone within the previous 3 months, but we didn't specifically ask about the context of use. Using data from the American Men's Internet Survey of more than 30,000 MSM, 10.3% had used crystal meth or GHB or ecstasy in the previous 3 months. And this was the first time I've seen ecstasy included in this kind of chemsex-related framing for analysis purposes. And here in Canada, 2 studies that paint very different pictures given the study population and sample. The The first comes from l'Actuelle PrEP cohort study, in which 24% of PrEP users reported sexual relations under the influence of cocaine, ecstasy, GHB, crystal meth, ketamine, or crack at least once in the last 12 months. While data from the EMIS study of 2017, which included more than 6,000 MSM in Canada, found 6.2% had used stimulant drugs to make sex last longer or feel more intense in the last 4 weeks, without making reference to the specific drugs used. All of these studies have added a great deal to our understanding, but they've also introduced dizzying complexity in terms of how prevalent chemsex really is. Every attempt I've seen at performing a meta-analysis across countries has largely failed, given this huge diversity that I've illustrated. But beyond just trying to establish prevalence, each of these studies and more besides have sought to understand predictors of chemsex and to establish among whom the practice is most common. Without a shadow of a doubt, chemsex is more common among men living with diagnosed HIV. Studies all across the world routinely find that men with HIV are between 2 and 5 times more likely to engage in chemsex, whichever definition is being used in that study, than those who are negative or untested. Unsurprisingly, chemsex is more common among men in gay urban centres, places like New York, London, Barcelona, but here in Canada, I'm sure that would certainly include Toronto, Vancouver, and Montreal as well. We commonly see an association between chemsex and selling sex, and sometimes have qualitatively observed a degree of transactional sex, where drugs are purchased by older men who provide them for use with sex that occurs with younger men. Generally speaking, however, there's quite considerable variation across the age range. In terms of behaviors or practices, we commonly see chemsex statistically associated with having a high number of sex partners and engaging in group sex. Surveys often report associations with other practices that authors have sometimes referred to as esoteric, although I'm always a bit conscious of using that kind of framing because it can come across as a little stigmatizing. And they report a higher likelihood of engaging in more adventurous acts, such as fisting or in water sports. If I'm to try my best to summarize all of that complexity, I think we can probably say that somewhere in the region of 5 to 12% of gay men in higher income countries may engage in chemsex, using the definition and the drugs that I described at the start. Engaging chemsex on a regular basis. And this is an estimate based on a very messy literature and by no means a hard statistic on the back of a meta-analysis. Moving along a little, we come to the question of why. What motivates some gay, bisexual, and other men who have sex with men to engage in chemsex? This has been the subject of a lot of media sex speculation, and often the answer in the media has been framed in ways that perpetuate a pathologization of gay men's sexual lives. I've heard people describe chemsex as a reaction to internalized homophobia, people using drugs as a means of overcoming or distancing themselves from shame that they feel for being gay or being HIV positive. A belief that gay men can't love themselves or one another due to societal stigma, othering, and marginalization. Drugs thus fill a void or facilitate a form of connection with others, one which is mechanical in nature and devoid of intimacy. Perhaps. For some, that may well be true, but I do strongly believe that the reality is much more nuanced than this. Back in 2016, the group I worked with in London set out to qualitatively explore meanings, values, and motivations associated with chemsex, and unsurprisingly, we observed a range of issues at play. It was the case that for some men, using drugs during sex helped reach or restore a kind of sexual life that they previously felt was out of reach, such as older men who had lost their libido. Men living with HIV who had a hard time at the point of diagnosis regaining their confidence around sex, where drugs provided something of a kickstart to their sexual arousal, and men who used drugs to mitigate impacts of trauma in their lives. Men who had body image concerns and felt that they simply paid less attention to these while using drugs. But the motivation for chemsex wasn't simply about overcoming cognitive barriers or concerns. It was also about enhancing or enabling aspects of sex that were really valued by the men we interviewed, such as the chance to make sex last much longer or the opportunity to significantly enhance sexual sensations. I've always loved this particular quote. This was a young gay man in this study, qualitative study, who told us about his sex while on methadone. And he said, "It was the best sex I ever had. I used to say it was like the heavens opened and it was like the light came down when I had an orgasm, because it was that intense on drugs. It really was. I've never experienced that sober." It sounds pretty compelling, right? And contrary to the dominant narrative that the sex on drugs is mechanical and unfeeling, many actually described it as an intensely intimate encounter. And if you could find the same level as your partner at the same time, there could be a meaningful and highly valued connection. Chemsex can be all of these things. And as I'll go on to talk about later, your motivations and what you value about engaging in it can considerably vary depending upon where you sit on a continuum. In summarizing this particular section, what I really want to do is centrally position the role as pleasure in the context of chemsex. Yes, it's the case that some men use drugs to overcome or mitigate certain negative forces. But by far the most salient, significant, and common reason for using drugs during sex is that they facilitate sexual pleasure. Failure to recognize that will prevent any clinician, any counselor, or any peer worker from meaningfully engaging with a man who engages in chemsex. I actually think Canada has been better at than most other countries in recognizing this. And I love this quote from Rusty Suleimanov, who I think is sat right down here, and his colleagues back in 2019, which encourages us to think about why chemsex may have emerged as a phenomenon at the point it did. They said, "The transition from condom-centered prevention to today's context where new, highly effective biomedical tools for HIV prevention are available created possibilities for greater intimacy, increased pleasure, and less anxiety about HIV transmission, while challenging many years of preventative socialization among gay and bisexual men." Essentially, I think, saying that this new biomedical era has shaped an environment in which this kind of sexual expression and adventure feels more possible than perhaps it once did. And a separate quote from my friend Jorge Flores Aranda, who's at the University of Quebec, Montreal, and his colleagues, who stated, "For those who accessed services, the services were very little adapted to their reality. In effect, stopping methamphetamine use signifies the loss of the pleasure associated with the use of this substance, notably with regards to their sexuality. In consequence, participants spoke of needing to mourn their sexuality, an issue not dealt with in most therapeutic follow-ups. A strong reminder that pleasure has to stay front and center in our minds as we consider this topic." Excuse me one moment. But despite everything I've just said about pleasure and the nuancing of historically deficit-based framings of chemsex, there are risks, and there are harms, and there are consequences. And to not acknowledge this would be a disservice to those who sometimes require our support and intervention. These harms come in many forms, but this is a sexual health and HIV conference, so let me start there. There have been upwards of 80 published studies where data about drug use in sexual contexts is captured alongside data about STI diagnoses. Fortunately, these have been the subject of 2 robust systematic reviews, the latter of which I was involved with, and both tell a convincing story. Without question, there's a clear association between engaging in chemsex and having received an STI diagnosis in the last 3, 6, or 12 months, anywhere between 2 and 5 times more likely than those not engaging in chemsex, depending on the context of data collection. From my perspective, this is a matter of mathematics. Chemsex allows you to have sex for longer and maintains you in a state of arousal where you can have sex with more people, possibly in quick succession. Where there's a high coverage of PrEP use, an undetectable viral load among participants, so the likelihood of condom use is lower. And these combined are the ideal circumstances for the transmission of STIs, particularly bacterial ones. When it comes to chemsex and HIV, I'm still not convinced that in high-income contexts, where there's a clear relationship between I'm not convinced that in high-income contexts, there is a clear relationship between engaging in chemsex and risk practices that result in HIV seroconversion, certainly not at a large scale. High levels of undetectable viral load in the community of people living with HIV, coupled with high rates of PrEP use among men engaging in chemsex, something I'll come back to in just a moment, means that the likelihood of HIV transmission in most high-income countries with good coverage of biomedical prevention technologies is likely rather low. At present, though, we simply don't have the longitudinal studies where there's sufficient data of a high enough quality to really be able to answer this question with certainty, partly due to all of those issues of measurement and case definition that I spoke to earlier. And I think there's a particular need to examine this issue regarding the potential for transmission among people from ethnic minority and indigenous backgrounds, where we see lower rates of engagement with biomedical prevention technologies. But our HIV-related concern rightly extends beyond seroconversion to also include ART adherence for those already diagnosed positive. In this respect, there has been some movement in the literature. Back in 2014 or 15, several studies on the relationship between chemsex and ART adherence reported no negative association. However, fast forward to the last 2 years, and we have seen some examples where ART use among those engaging in chemsex was suboptimal compared to those who did not use drugs during sex. The second example here was a study I worked on with colleagues in Europe across 4 different countries where we examined chemsex among patients at HIV-positive clinics. More than twice as many men engaging in chemsex had missed ART doses compared to those who hadn't engaged in chemsex, a pattern mirrored in the first study listed there as well. However, before we hit the panic button, it's worth noting that in neither study was there an association with viral load detectability, indicating that their reduced adherence was not so protracted as to negatively impact their overall HIV clinical outcomes. But there are, of course, a range of other potential harms to be mindful of in the context of chemsex, and I'll talk first to mental health. Crystal methamphetamine can trigger intense feelings of sexual arousal, but overuse can be associated with paranoia, irritability, or even psychosis, either from the drug effects themselves or the ensuing come down. There are an increasing number of case reports and qualitative studies describing exactly this experience. However, it's worth noting that at the level of global association between chemsex drug use and mental health, this is a very mixed picture. While some studies have reported that those engaging in chemsex have worse mental health outcomes than those who do not, other studies, including 2 I've been involved with in Australia, do not reflect this association. Indeed, Field and his colleagues this year reported how engagement in chemsex was associated with lower odds of anxiety and depression. Now, the authors were at pains to say that they aren't proposing chemsex as a remedy to poor mental health, but rather they hypothesized that something about the social connectedness of chemsex and the very often dense social networks in which it happens may act as a protective factor for mental health, which is something supported by some of our qualitative work among people living with HIV as well. There's a wide range of other potential harms, of course, and I'm not going to go through all of them in detail. Overdose I'll speak to more in just a moment, as with sexual assault. The other harms, the potential for relationship damage, financial costs, legal consequences, many of these are much more likely to be experienced by the minority of people who find themselves in more challenging circumstances, those at one end of a complex continuum. The stigma of drug use, however, is rather universal, and sadly reflects stigma that has been directed towards people who use drugs across our societies for many decades. As with all types of stigma, it can act as a barrier to people seeking help or providing help when it's needed. Stigma around drug use, especially in sexual contexts, makes it hard for many to even mention their experience or their need for support with family or friends, or discuss it with their clinicians. A drug that's often caused concern is GHB, gamma-hydroxybutyrate. The 2021 version of the Canadian Sex Now survey showed that 7.7% of gay, bisexual, trans, two-spirit, and queer men had used GHB in the last 6 months. For those not familiar, it's a drug that you take in a liquid form in very small, very carefully timed doses. It's exceptionally easy to overdose, and a high proportion of frequent users have done so. Overdose can result in respiratory depression, and it's not uncommon for those who have overdosed on GHB to choke on their own vomit. There have been a very large increase in GHB-related deaths in a number of countries, including in the UK and in Australia. Recently, a PhD student of mine, Jack Freestone, has been studying GHB use in more detail and conducted in-depth interviews with 31 people in Australia who reported GHB use in the previous 6 months. In an article we published last year, we articulate the experience of using GHB across 2 domains, where we first outline the perceived value to the participants, the pleasures, before then exploring the possible or experienced risks and the way that participants did or could manage their use more effectively. And that's what's reflected in those 3 columns. The first domain is about how participants use GHB in pursuit of a gratifying high. GHB use was associated with a range of unique, pleasurable sensations described by terms such as relaxation, disinhibition, increased confidence, euphoria, as an aphrodisiac, relatability, and social connection. But the propensity for GHB overdose that I mentioned a moment ago brings with it a number of risks that men had to manage. The risk of losing consciousness, vomiting, accident or injury, or hospitalization. But these risks can be mitigated by adequate preparation, educating oneself or one's peers about the safe use of GHB, getting reviews from peers about the quality of a particular batch, and then by very carefully dosing and very carefully timing one's use, ensuring as well not to mix with certain other substances, and especially not mixing with alcohol. The second domain in the paper is about the association with connection, exploration, and relationships. The interpersonal connection, depth, and understanding afforded by GHB was described in direct relation to the disinhibiting components of the GHB high, and reportedly produced intense pleasures in the moment and incurred sustained relational benefits for participants. The relational components of GHB use were overwhelmingly recounted as positive. However, a few participants recounted distressing experiences caused by others. Most often articulated was the experience of responding to someone else's overdose, an act thought of as an inconvenient duty of care at best and acutely distressing at worst. GHB sexual violence was also reported. A small number of participants recounted experiences in which they'd either been pressured or made to unknowingly consume a high dose of GHB by someone who proceeded to then have sex with them. Several participants engaged in GHB-enhanced sex with partners and recounted experiences of others having sex with them while they were not conscious. We explored this issue of consent further in a specifically focused article published late last year using the same data set. Several participants narrated experiences of GHB sex that they felt were distressing and in some circumstances could objectively be framed as sexually violent. In some instances, participants resisted terminology of sexual violence or non-consent as descriptors of their experience. This was language it seemed that they didn't feel was accessible to them. Perhaps we surmised due to the heteronormative ways in which intimate partner violence is often reflected in public discourse. And I think this is a particular issue that warrants further attention. As I hope I've made clear, there's compelling evidence that using drugs to enhance or facilitate sex is highly valued by many of the men engaging in it. I'm cautious about pathologizing everything about the sexual lives of this population, and I don't believe that chemsex is inherently problematic. It can be affirming and pleasurable. But for some people, it does become a problem. They do experience harm, as been particularly evident in my discussion of GHB use and crystal meth use. Understanding the circumstances of harm is crucial if we're to design and deliver support to those who need it. I think we can do much better in terms of understanding and reflecting the continuum of chemsex experiences. What I'm presenting here on the screen is my general sense of what that continuum could look like, drawn from 10 years of research in this space and from reviewing dozens of articles in the field, although I've no doubt it requires considerable nuancing. Much of the public and media attention has been fixed at the far end on those people who are in some form of crisis, and I wish to use that phrase carefully. These are people who really are having it tough. They're in acute mental health circumstances, they may have overdosed repeatedly, and they may be isolated from the very support that they would benefit from. But my sense is that most people find themselves further to the left. They're using drugs during sex for more specific purposes at specific times. They're considered about the drugs they use and how they use them. But sometimes that shifts and changes. Come downs become worse, a preoccupation can develop, it can become challenging to have or even imagine sex without using drugs. My goal in suggesting such a continuum is not to propose that everyone is destined to move from the left to the right. This is not an inevitable journey, but rather to illustrate some signifiers of when chemsex may be becoming problematic. To encourage questions that could be asked of clients and service users to establish the nature of their relationship with chemsex in ways that understand and affirm the value people may derive, while at the same time staying attentive to signals that external support may be required. In this last section, I want to turn attention to some of the interventions that can be deployed to reduce harms associated with chemsex if they occur. And again, since this is a sexual health conference, let's start with reducing harms to sexual health. This is a schematic of harm reduction strategies that I recently worked up with the same group of colleagues in Taiwan. It seeks to outline the various harm reduction strategies people can employ before the chemsex session, shown in the green font, during the chemsex session in the red font, and after the chemsex session in the blue font. The Venn diagram shows drug use at the top, HIV management on the left, and sexual health management more broadly on the right. We hope it provides a valuable summary for both clinical and community practitioners and assists with both service planning and community-level harm reduction education. There's a role here for pre-consideration and discussion of sexual preferences, of personal self-care, and for education and empowerment. But what's also apparent, of course, is the role of biomedical prevention technologies, both in terms of treatment as prevention, but also in PrEP use. In fact, surveys all over the world routinely observe that people engaging in chemsex are much more likely to be active daily users of PrEP compared to those who don't engage in chemsex. And this perhaps suggests that there's a recognition among those engaging that they are potentially at a high risk of exposure in the context of their sexual lives. In Australia, we've observed an increase in the coterminous use of PrEP, methamphetamine, and Viagra, which, in an attempt to be clever and hark back to the 1990s, we named the new MTV generation. But as I made clear in my earlier slides, the potential harms associated with chemsex extend far beyond those related to HIV and sexual health. An important aspect of chemsex to hold in mind is that it often takes place within relatively dense, sometimes quite well-connected social networks. And these provide great opportunities for dissemination of harm reduction information and materials. Across the world, I really do think it's community organizations that are leading the way in terms of the broader harm reduction response. These organizations, of which I know there are many excellent examples here in Canada, are experts in engaging the very populations that are most likely to engage in chemsex. And in doing so, they're drawing on 40 years of experience enacting HIV education and health promotion. There are a very wide range of interventions that have been deployed across the world. Group work or individual therapeutic interventions, online interventions, peer-based education, community mobilization efforts, including everything from film production to chemsex poetry evenings, party planning, and much more besides. Ultimately, the utility or role of each depends on which of the many potential harms you're trying to address. One of our own community organizations in Australia recently reviewed evidence about drug use interventions for gay and bisexual men and drew out 5 key principles that they propose should inform all such work. Some of these are likely familiar to us, but they serve as a timely reminder that any drug-related intervention needs to hold at its core the goals that the individual wants to work towards. It needs to be led by their preferences, be that for more managed use, reduced use, or abstinence. It needs to recognize that not all men who have sex with men are the same, and that intersectionality shapes experience and outlook. Interventions must be sex-positive, trauma-informed, they must be designed with community, and where possible, recognize the crucial role that family and friends can play in efforts to better manage drug use. If I highlight just a handful of examples where I've seen good quality harm reduction interventions, this is one from an LGBTQ organization in my home state of Victoria in Australia. Touchbase is a highly sophisticated drug use harm reduction education website targeted men who have sex with men that has around 150,000 unique visitors a month, many coming from outside of Australia. It provides valuable information about safer drug use techniques, advice on managing your mental health and that of your friends or sex partners. There's a toolkit for reducing use, if that's your goal, and referrals into therapeutic services for those who might benefit from them. In preparing for this talk, I also came across a great resource that's recently been published by the Gay Men's Sexual Health Alliance here in Canada. I was pleased to see it include valuable information about responding to an overdose, managing come-downs, respect for relationships on the chemsex scene, and advice on the role of PrEP and ART adherence. We're starting to see some of these interventions be evaluated, although such research is still in its very early stages. And to date, I've only seen one randomized control trial of a chemsex intervention, recently published from a study in Hong Kong, although I think this is a very different context than one we're in here, one where PrEP use is considerably lower, and one where there was more of a focus on condom use and on HIV testing following that intervention in Hong Kong. Other evaluated studies have tended to focus on therapeutic interventions where methamphetamine use is considered and where the outcome assessed is alignment with person-centered treatment goals relating to more carefully managed use. Such evaluations have shown promise, particularly the first 2 on the screen here that make use of motivational interviewing techniques, a method designed to strengthen personal motivation and commitment to a specific goal by eliciting and exploring a person's own reasons for change in an atmosphere of acceptance and compassion. When considering the challenges associated with delivering chemsex harm reduction, a similar pattern of issues has been evident in health systems all over the world. Inefficiencies in client pathways, people being lost to follow up when referred by a sexual health service, for example, into an alcohol or other drug use service, something we can remedy by the co-location of such staff within sexual health settings. These are spaces that we spent 40 years making more affirming and comfortable for gay and bisexual men, so let's make use of them. But let's also ensure that staff working in sexual health settings have a sufficient understanding and sensitivity towards chemsex that they need. Restrictive funding or commissioning environments, sexual health funders who feel chemsex is a drug use issue, and so the costs of intervention should be covered by alcohol and drug use funding streams, and then vice versa, meaning that no one invests the funds that are required at the scale they're needed. A mental health workforce that sometimes isn't adequately trained or even at times sufficiently inclusive to understand and meet the needs of this population. These are complex and highly sensitive issues to discuss, and a high level of cultural safety is required before some men engaging in chemsex can feel comfortable talking about their use. I hope this talk has provided a valuable overview of where we've got to in the last 10 years, but of course there's always more to do. And in closing, I want to highlight just a few key areas that I feel warrant further attention in the next 10 years of chemsex research. It will remain a considerable challenge to accurately understand the prevalence and patterns of chemsex without establishing some standardized data collection tools, and this is something I'm especially keen to work on next. As I hope I've made clear, not all gay men engage in chemsex, and not all men who engage in chemsex do experience problems, but some do. And I think we're still not as sophisticated as we need to be in understanding when and for whom this may be the case. Research that more carefully examines problematic use is sorely needed. At an international level, I think research is needed to help understand how legislative, policy, and cultural environments shape engagement in chemsex and the design and delivery of harm reduction interventions. With some of the world's most liberal approaches to drug use reform, Canada is an obvious potential leader in this field. Understanding safe supply of drugs involved in chemsex is still in its infancy, although I did see a great talk by a PhD student from British Columbia last week at the International Harm Reduction Conference. There's much more to explore here, given the role that drug quality can play in shaping harmful outcomes. And now is the time to evaluate. We've witnessed a great many creative and I'm sure likely impactful interventions arise from community organizations and in clinical settings, but evaluation of such work has been extremely limited. Without more robust evaluation of therapeutic interventions, of community-based and online interventions, and broader harm reduction interventions, we simply lack the evidence base that is required to inform the design and the funding of services and programs at the scale that is required. Thank you very much for your attention.
Alarm, I'm coming. Thank you very much for your huge and impressive presentation. Would we have some questions or comments? One, maybe. Yes? Could you come to the microphone?
Well, actually, I have two questions related to GHB. In the people that you saw, do any mention like not knowing the difference between GHB and GBL when they were doing overdose? And also the second question is like, do they know about the danger of trying to stop when they have an addiction of GHB because I see that often people doesn't know that they maybe need medical assistance for that, and that's actually scare me a lot when I see that.
Yeah, on the second point, I think it's not at all well known that if you've been a protracted user of GHB, you do require medical assistance in kind of stepping away from that, and not doing so can be incredibly problematic. And that level of community understanding of that is very, very poor, I would say. In relation to your first point, we didn't quite address it because in Australia, really it is only GHB that is available. GBL doesn't occur in quite the same way there, so it wasn't something that we touched on, but it was a fair question.